Welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED Expo 2024. My name is Jim Case, and I'm the Chief Terminologist at SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter, and on-site attendees, please use the microphone that will be provided in the room. I'm now pleased to introduce Andrea Riedel from University Hospital Erlangen and Catalina Martinez Costa from the University of Murcia, who will be presenting using SNOMED CT as a reference medical terminology for the European Registry of Stroke Care, RES-Q+. Andrea and Catalina, please go ahead.
Good afternoon. My name is Andrea Riedel, and I'm a doctoral student at the Data Integration Center of the University Hospital Erlangen in Germany. I'm very thankful that I could visit my supervisor, Catalina Martinez Costa, for a 2-month research stay at the University of Murcia. The fellowship of the German Academic Exchange Service supported the stay. During that stay, I was involved in the work package for semantic interoperability of the EU Horizon project RESCUE+. Today, we want to present the results about the mapping validation process and the challenges and opportunities in using SNOMED CT as a reference medical terminology in questionnaires for standardizing stroke registry data. RESCUE+ is a European project of a period of 4 years based on a huge global registry of stroke care quality. The left figure shows the large number of 1,600 participating hospitals with over 850,000 patients in over 70 countries. The overall project goals of RESCUE+ are to improve the quality of the European healthcare system, to save patient lives and decrease healthcare costs. The project includes capturing data on the whole patient pathway. 2 virtual assistants will be developed. 1 voice assistant helping patients improve feedback on health status, and another assistant helping physicians in stroke care management. Moreover, the data entry into the registry should be automated by using NLP with a clinical validated semantic model. My work during my research stay focused on the support of the last goal. As it is a huge project over multiple hospitals and countries, each have their own languages, systems, and documentation workflows. An NLP tool now automate and facilitate the fill of the rescue questionnaire out of the individual discharge letters into the rescue form. Local nurses no longer need to manually fill the questionnaires and only serve as human validators. This is a first step to create structured out of unstructured data to transform heterogeneous data of different languages in a standardized EU form for a common registry. Nevertheless, a free text questionnaire form is still not perfectly machine readable or exchangeable. To increase interoperability, RESCUE+ has the goal to create a standardized exchange interface for data reuse based on a semantic common data model including knowledge graphs. This semantic harmonization should eliminate redundancy or ambiguity, be integrated into the NLP pipeline, and facilitate data analysis. Moreover, it should also support semantic interoperability with other registries. As a foundation of the semantic harmonization layer, SNOMED CT was chosen. In project reality, not everyone is familiar with technical details, especially in interdisciplinary teams. Limited project time often does not take into account that interoperability tasks like the annotations needs time due to its complexity. For example, no annotations guidelines for these use cases were available. Therefore, we created a facilitated training in form of a short introduction into SNOMED CT and a validation task during a project meeting. Our interdisciplinary mapping validation process consists of 4 steps. First, 2 technical SNOMED CT experts transformed the questionnaire form into a facilitated tabulator form for mapping and validation. Then, stroke expert teams focused on the validation of different form parts from a medical point of view according to a traffic light system validation. Green means agreement with the SNOMED CT expert annotation. Yellow means that a comment was added, and red means that there's a disagreement with the SNOMED CT expert. In the third step, an external physician with great SNOMED CT expertise conducted the second validation. In around 72% of our items, we could reach an agreement between SNOMED CT experts and validators. If no agreement was reached, then we defined a disagreement. In 30.2% of the cases, both annotators disagreed with the mapping. In 40.4 cases, at least one annotator disagreed with it. In both cases of disagreement, another stroke expert was asked for a final revalidation. The rescue form contains different questions about hospitalization, treatment, and post-treatment of post-stroke patients, with 124 single and multiple choice questions in English language. In total, over 470 individual items need to be mapped and represented in knowledge graphs. Nevertheless, there are strongly limited free text elements in a predefined format, as you can see in the screenshot on the left, showing the discharge date. To facilitate a mapping validation task for the medical validators, we separate headings, questions, and answers, as you can see here for our example of the MRS score on discharge with a quantitative result of 6. The modified ranking scale is a commonly used scale that measures the degree of disability or dependency in daily activities of people who have experienced a stroke, ranging from 0, no symptoms, to 6, death. Contextual information representation, temporal, numeric, or provenance aspects, like the discharge date or the answer between 0 to 6, were excluded of the mapping to SNOMED CT and represented in the information model like SNOMED CT. Even though we made questions and answers separately to facilitate the mapping validation workflow, all information over different questions regarding a patient need to be represented together. With the help of knowledge graphs, all information of a patient is accessed via its case. There you can find, for instance, different procedure and observations of the patients, such as the MRS score of the patient at discharge. Especially the information of discharge shows that it is very important to represent this in context. MRS score is an observable, and depending on when it is observed, given by the procedure, it has to be interpreted.
In total, around 300 different pre-coordinated concepts were used to represent the form's content. 64% of the whole content could be represented by using SNOMED CT, either using pre-coordination or simple or relatively complex post-coordinated expressions. And in this case, assuming that simple contextual information such as done, not done, present, or absent was represented by using the information model. In 25% of the cases, it was not possible to represent the form element using SNOMED CT, either because the information model was needed, the concept model did not support the required post-coordination, or there were missing concepts that in some cases also prevented post-coordination. Finally, in 11% of the cases, there were residual expressions like another, unspecified, elsewhere, that were common in answers and not possible to represent in SNOMED. Now we will see some specific examples for each case. As mentioned, in 35% of the cases, it was enough using pre-coordinated concepts. However, in 26%, relatively complex post-coordinated expressions were required. They usually correspond to procedures and conditions at specific body locations, but also to specific drugs or substances, administrations, and prescriptions. For instance, for expressing that all infarcts were seen on the brain imaging and specifying the site of the brain where they occurred, which could be either the basal ganglia or the internal capsule of the brain. In that case, the post-coordinated expression is built by using the imaging finding together with the associated morphology healed infarct to express that it was an old infarct and the corresponding finding sites. And both expressions are joined with an OR. In a quarter of the cases, either the information model was needed, like for instance for expressing temporal context, or no mapping was possible due to different reasons, concept missing, or no support by the concept model of the intended post-coordination. Let's have a look at that. Here, an example of the need for the information model. We would like to represent the fact that the thrombolysis treatment was performed together with its context. This is done through the information model that, using the clinical procedure statement, allows to link the thrombolysis procedure with where at the hospital it happened, in this case at this hospital-based radiology facility, and when it was performed, at which date time. In a similar way, in case, for instance here, the thrombolysis was not done, we would like to be able to specify the reason for not doing it, like here, consent not given by the patient. This requires, again, of the information model, and as in the previous case, using the clinical procedure statement information entity, we will link this information, the fact that the thrombolysis was not done, with the statement that represents that the consent was not given by the patient by using the procedure-reason relationship. Another reason that I mentioned for not being able to map the form element is no support of the concept model for the intended post-coordination. Here we see an example of an observable entity temporally qualified by expressing that we want to record the age at the stroke onset. If we look in SNOMED CT, we find similar concepts for other conditions. For instance, age at onset of menopause or at onset of menstruation. However, they are not formally specified by using the concept model, which prevents the building of post-coordinated expressions for other conditions, no? For instance, type of stroke symptoms, or as mentioned here, age at stroke onset. A more complex example of expression that is not possible to represent by current post-coordination rules is the fact that the patient was admitted to one department, for instance, neurosurgery, and this department included a monitor bed with telemetry. The question here is if it does make sense to build such an expression by post-coordination, and if so, how? I can represent this by using individual concepts. For instance, I can represent that the patient was admitted to the neurosurgical department. I can also, however, what is not possible is to connect this procedure with the environment concept that represents the neurosurgical department. I can also refer to a standard bed with telemetry as the conjunction of both physical objects. However, again, what I cannot express is that they are linked with the specific department in which they are located. The third reason for not being able to map the four elements to a SNOMED CT is a concept missing. This occurs very often with assessment procedures such as the Salowin test assist test, for which we did not find any concept. But also in some cases, there is a missing concept when building a post-coordinated expression, such as wake up stroke. We did not find a way to express the fact that the stroke occurred while the patient was sleeping. And finally, in some cases, there are residual expressions in the form answers, such as another, unspecified, and elsewhere. For example, here, other anticoagulant. For expressing that, we need to explicitly negate the previously enumerated anticoagulants. But also sometimes it's not possible to enumerate everything, as for instance, the concept stroke mimics. This means everything that is not a stroke. Or how to represent other expressions like embolization to different vascular territory. Different from what? Or same hospital, or another hospital, and so on.
In conclusion, a continuous exchange with SNOMED CT International and more guidance in the use of SNOMED CT in the context of an information model would be beneficial for big research projects. While capturing registry data, it is necessary to strengthen the interface between medical and technical experts. Also, limited implementation resources and the training of medical experts should be balanced. We face issues of limited terminology precision in terms of medication categories, stroke-related tests, and so on. Furthermore, monthly versioning or post-coordination limitations due to range constraints make the mapping process more complex. Moreover, questionnaires have their own language peculiarities like yes and no, unspecified, or other. Questionnaires often have linguistic specialities like abbreviations or geographical or institutional terms which should be avoided. Last but not least, translation issues can occur in multi-country projects. In the future, a specific annotation guideline for questionnaires would be helpful. We also plan a specific stroke-related reference set based on our results of the Rescue Plus project. Finally, we strongly recommend the combination with an information model such as HL7 FHIR. We want to thank you for your interest and all project members for their support. We would be happy if you take a look at our recently published paper on this topic for more information. If you have further questions, feel free to ask now in our discussion round or to contact us via LinkedIn or email.
Thank you, Andrea and Catalina. Catalina will now be joining us from Europe to take questions. As a reminder, if you're in the room, please use the microphone to ask your question.
Thank you, Tim.
You're online? Okay. Thank you for your presentation. So I have a couple of questions to you. So when you post-coordinate your concept, especially I think some kind of medication given, I think that they should belong to situation top level hierarchy. But you use the attribute, for example, temporal context, procedure context, but you use the other attribute that according to SNOMED CT concept model that you're not supposed to use. So I was wondering, who's validating your post-coordinated expression? So I was wondering that's my first question. And then the there are a lot of things we could solve the issues you raised by using information model, right? So, and according to your presentation, you really try to map or do something about SNOMED CT, every single expression. So I was wondering, when you select the candidate for mapping, how do you, what kind of rules do you use, or what kind of criteria you use for selecting candidate concept to map SNOMED CT? So those are my questions.
Yeah, thanks for the question. So first, exactly, so we need an information model, and we use an information model. So this means that we don't want to use the situation with a splitted context hierarchy, and because there is always an overlapping of this hierarchy with the information model. So then this was one requirement, not using it. And then, yeah, we have in the background, really, we have, as you have seen, we have attributes like procedure context, situation context, finding context. Yeah, so the thing is that this belongs to an ontology, no, in fact. And then, yeah, so the SNOMED CT is used just for, yeah, really the medical concepts. And yeah, so yeah, I think it's, yeah, here it wasn't clear, but at the end, we are translating everything into a knowledge graph. And that's why we have ontologies behind. So we want to encode this medical knowledge with the SNOMED CT plus an information model. So this information model is expressed in a generic way, first in the ontology, with the idea that you can later translate it to FHIR, for instance. Yeah. So that's the idea. And of course, we had several like rules for selecting the right SNOMED CT concept. So depending on, for instance, if you are going to attach value, quantitative value usually, so you select observables, or if you, yeah, there were certain rules, for that. And regarding who validated post-coordination, so two SNOMED experts, I mean, technical experts validated it, because of course, yeah, we couldn't expect from clinicians not to validate it. And that was, or even to post-coordinate, because this was very, very, very complex. So the review process. So we had to really simplify it for them, because yeah, the form to express everything, it was really full of post-coordination, and so it was not possible to teach clinicians to make this. No, we didn't have enough time, resources, so we were more focused on please validate that this is not what the medical meaning that you want to express. No, it was a complex process. I don't know if I answer all the questions.
Thank you, Catalina. Are there any other questions? Do we have any questions in the Q&A? It's very quiet. So with that, this will conclude this session. Online delegates, you can stay here for the next presentation in the stream or access another session through the event lobby. Thank you.
Thank you.